Take it away.
So thank you, and it's really a pleasure to be here to talk about retroperitoneal sarcoma and extremity sarcomas. So I have no financial disclosures, but do want to mention from the start, and you'll sort of get this trend throughout, that the management of sarcoma is based on some combination of science, practice, and belief, and that's probably more true for sarcoma than it is for a lot of other cancers. You'll see this come up, but there are a lot of sarcomas, and their cancer is very different, or their behavior is very different, and they're very rare. So when you have a whole lot of different diseases that get clumped together, and they're rare, we do our best to manage things with science, but some of it's extrapolated. So as Dr. McAllister pointed out, I was born and raised in New York City. My wife and I met in college and she's been following me all over the place. I did med school outside of New York City, residency in Denver at the University of Colorado. And one of the pertinent pieces about this is when you grow up in New York, if you tell anyone from the East Coast that you're from New York City, they look at you with this blank stare because there are 10 million of you from New York City. It would be like meeting someone from the Midwest and telling them you're from the Midwest. So I spent my whole life until moving to Denver telling people I was from Manhattan. And someone in Boston knows what that means. And it turns out if you tell someone in Denver you're from Manhattan, they start talking to you about how much they love K-State or how much they hate K-State or whatever. And this was long before I knew I was going to move here and like it. And so I was like, I'm not talking about Kansas. No, I'm talking about New York. And lo and behold, a couple of years later, I now live in Kansas and very much like it. But after Denver, moved to Ohio State, or the Ohio State, for Sir Jonk Fellowship, and have been here now for about a year and a half. And as Dr. McAllister said, I've got two sons, Andrew, who's a fourth grader, and Jackson, who's a first grader, and they are firmly Chiefs fans, and which probably everyone in the state agrees with. And for those of you who aren't K-State fans, you'll be happy to know they're KU fans. And so they are unaccustomed to their teams losing, which is both probably good and bad to grow up as a kid that way. But my clinical focus, I do a lot of cutaneous malignancies, and I do a lot of soft tissue sarcoma work. And then with a little bit of peritoneal surface malignancies and a little bit of solid tumors of the GI tract. But really, honestly, I'm happy to see, and I'm trained to see, anything weird that you think needs to be seen by a surgical oncologist. And that's certainly soft tissue sarcomas of the trunk and extremities fit that bill. So the whole point of today, hopefully, I'll describe the workup of a newly identified subcutaneous mass and give you some hints for the clinicians on board, or for the non-clinicians, when you should be worried about something, when it can stay where you are, when it needs to be referred to a specialty sarcoma center. Likewise, for subcutaneous masses wherever they are, but then also desmoid tumors, both of the abdominal wall and intra-abdominal desmoids. And then the bulk of today is going to be talking about the workup and management of retroperitoneal tumors, focusing on some pre-op and then some intraoperative decisions that we end up making. So basics about sarcoma, as I said in the beginning, sarcomas are really a very heterogeneous group of tumors. Based on where they grow up embryologically, they rarely travel to lymph nodes. There are 5 tumors, the CARES group, that do have a rate of lymphatic metastasis, but basically everything else is, if they do spread distantly, they spread via hematogenous dissemination, which means generally their first site of metastasis is the lungs. They represent less than 1% of all adult tumors. They do represent about 7% of childhood malignancies. The treatment is histology and location specific. And one point to make about this, and this really fits in with the fact that histology evolves too. One of the dominant histologies that we see in the retroperitoneum is called well-differentiated liposarcoma. This is a sarcoma that originates from the fat of the retroperitoneum. And if you take a biopsy and you hand it to a pathologist and you tell them that it comes from the retroperitoneum, they will call this a well-differentiated liposarcoma. If you take literally the same slide and give it to a pathologist and tell them it comes from the extremities, they'll call it an atypical lipomatous tumor. And that's because it's the same molecular mechanism that led to tumor development, and it's the same appearance under the microscope, but the biological activity is totally different. So it has a different name. And this pie chart here is a pie chart from a paper that was published out of Sloan Kettering at this point almost 10 years ago. This was their experience with 10,000 sarcoma patients treated at their institution. These are the dominant histologies. And some of these histologies didn't exist when they started, and some of these histologies don't exist now. And if you look, 28% of it is other. And that really gets to the fact that there are now over 100 subtypes of sarcoma. And these subtypes are being defined as we understand more of the molecular mechanisms that drive sarcoma development. This is how they're being defined. This fits into, on the more medical oncology side, the clinical trials used to be high-grade sarcoma, and then they turned into synovial sarcoma. And now they're clinical trials that are coming down the pathway are specific clinical trials for specific mutations that are driving this. And we're seeing this in other solid tumors too, but we're not yet at the point with other solid tumors where we recognize just as many as we do sarcomas. And so it's one of the highlights here, and you'll hear this again and again, expert review, both at the path level and then at the treating team level. And that's not to imply that the pathologists aren't part of the treating team, because they absolutely are, is essential to what we're doing. So now to talk about extremity sarcoma a little bit. Over 80% of extremity sarcomas come from the soft tissue, and that's really what I'm going to be talking about here. The rest that come from bone, these tend to get referred out pretty quickly. But the dilemma that we face is that over 99% of soft tissue masses in the extremity are benign. The problem with that is an unintentional excision of something that you thought to be benign, and you thought it was a lipoma, or you thought it was a epidermal inclusion cyst or something, dramatically upstages it. So this is a survival curve from one of many retrospective reviews in the literature, both in the orthopedic literature and the surgical oncology literature, that's looked at referrals to their institution and the impact that intentional or unintentional excision had on recurrence. So you can see all comers, patients that got a planned excision have very low rates of recurrence, a little bit over 10%, probably over 5 years. But patients who had an unplanned excision, and that's a surgeon takes them to the OR thinking they have something, and then it turns out the final pathology showed it something else, their recurrence rates are much, much different. It turns out that the risk of recurrence is really related to what the re-excision pathology shows. So if you get an excision, you find out it's a soft tissue sarcoma, and then go back for re-excision. If there's no tumor left behind on that second specimen, the risk of recurrence is not zero, but it's certainly higher, or it's certainly better than if there's microscopically positive disease on the second operation, or even macroscopically positive disease on the second operation. And so, to put this in one sentence, most things that are thought to be lipomas are lipomas. And again, it's over 99% of soft tissue, subcutaneous soft tissue masses are benign. The problem is, if you think it's a lipoma and it's not, and it's in fact a sarcoma, and if the patient's unintentionally excised, you have dramatically upstaged them. So some general rules that have evolved are, if the soft tissue lesion is greater than 5 centimeters in size, then rule of, that's about the size of a golf ball, or if it's deep to the muscle, you should absolutely stop what you're doing. If that's not, the chances of that being a benign thing are low enough that you need to do some other work. So if it's raising the hair on the back of your neck, get some imaging. In general, ultrasound or MRI is the way to start. And really, in general, MRI is the way to start for these things. And MRI is going to give you a great view of what it looks like. You get it with contrast. You'll get several different views. It gives our radiologist a lot of information. And then it also, at the same time, gives really good surgical planning, because if we're going down the path that this is something more nefarious, that's going to need to be excised by an oncologist in oncologic fashion, an MRI gives us really good three-dimensional understanding of where it lays with other important structures. In extremity sarcomas, there's no debate. A pre-operative biopsy or a pre-treatment biopsy is absolutely essential for treatment planning. This should be either a core or an incisional biopsy, and this should be done at the sole discretion of the operating surgeon. And the reason for this is rates of biopsy tract or incision seeding are quite high if they're not excised. And so the treating surgeon for an extremity sarcoma or for some truncal sarcomas needs to do the biopsy themselves, because they know where they're going to put their eventual incision. So they can ensure that the biopsy site or that the site for the incisional biopsy is excised. So if you're wondering when you should refer extremity masses, you should do it early. If you meet a patient comes into your office, or a patient comes into your partner's office with something that's a lipoma and it doesn't seem like it's a lipoma, it's fine to get the imaging. But certainly that's where I would stop, and then I would send it along. If you're looking for something a little bit more definitive than early, these are guidelines from the Department of Health in the United Kingdom for what extremity masses need to be seen within 2 weeks. And so this is, again, a soft tissue mass that's greater than or equal to 5 centimeters. And again, golf ball size or larger. If it's painful, lipomas don't hurt, right? Lipomas are there and they're painless forever. If it's a lump that's increasing in size, and this is not, it's gone from 1 centimeter to 1.1 to 1.2 centimeters over years. This is like actual real change in growth that the patient appreciates. That should definitely be referred. If it's deep to the muscle fascia, or if you had something that was excised and the path has been lost, or it was excised in an office procedure and not sent for path or whatever, and it's come back, all of those need to be referred and need to be referred sooner rather than later. So now on to truncal sarcomas, and you'll see for part of this, it's really the same thing over again. So not all lipomas are lipomas, and you need to have this in the back of your mind. But then again, most of them are, right? More than 99% of soft tissue lesions are benign. But the sarcoma surgeons in the world, I actually have started getting referred some benign lipomas that'll get imaged, and there's a concern for it being a liposarcoma, and that's great. And it's I would so much prefer to see those than to see something that was incorrectly thought to not be a sarcoma and then get sent in a little late. That's what I see more of. If you're concerned about it, get an image early. Again, ultrasound or an MRI is a great place to start. If you're concerned, refer it early, but please defer the biopsy to the treating surgeon. We'll see it and we'll figure out what we're going to do. Desmoid tumors I'm going to talk about because they're a little bit weird, and the treatment has changed even over the course of my training. What used to be true is not true. So, sarcomas are rare, and within sarcomas, desmoids are quite rare. They're about 3% of soft tissue sarcomas. They're caused by an activating mutation in the beta-catenin gene, which for the purposes of this doesn't matter at all, other than to note that this gene, or the gene product, is downstream from the APC gene, which is the gene that causes familial adenomatous polyposis, which is why some APC variants develop intra-abdominal and truncal desmoids. For desmoid tumors, the anatomic location determines the natural history and treatment. This breaks down roughly, like everything else, into the extremity, the abdominal wall, and then intra-abdominal. And again, like anything else, start with really good cross-sectional imaging. For either the abdominal wall or the extremity, I would start with an MRI. For some of the patients that I observe, depending on the size and their stability on MRI, at some point we'll switch to ultrasound. It's easier, it's less expensive. But if it's an intra-abdominal desmoid, this should say CT abdomen and pelvis, obviously, but my imaging of choice is a CT scan with arterial and venous contrast. And that's because really what I'm trying to understand there is the relationship to the bowel wall and really to the vasculature of the small bowel. Intra-abdominal desmoids require a colonoscopy, either at the time of diagnosis or confirming that someone's had one. And this is because 10% of patients with FAP have desmoid tumors. Now, the flip side of this is only about 3 to 5% of patients with desmoid tumors have FAP. But since it's so common in FAP to have a desmoid tumor, if you have a desmoid tumor, you should absolutely either get a colonoscopy if someone hasn't had one, or track down their last colonoscopy report and see if it's consistent with a diagnosis of FAP. Regardless of the location of a desmoid tumor, surgery is rarely first line, and this has changed. And actually, I'll show you a paper that's 8 or 10 years old now, out of the group in Milan, where the first line of the abstract is surgery is the first line treatment for desmoid tumors. And I said, regardless of location, really what it does is it depends on progressibility, which is not resectability. Resectability, obviously, being our ability to take it out and get it all out. But one way to think about progressibility is progression of this tumor going to make the resection markedly harder or markedly more morbid. And this is generally the scariest with intra-abdominal tumors. But it's very rare that an intra-abdominal desmoid, and these often tend to grow at the root of the mesentery near the superior mesenteric artery. It's very rare that they will be resectable at diagnosis, but also not progressible. So it's they either tend to be involving so much of the mesentery that you can't go in and take it out, otherwise you'll place the bowel at too much risk, or they're not involving so much of the mesentery and there's a window for growth if they end up growing. And again, just to hammer this home, anyone who's got a mesenteric desmoid needs to get a colonoscopy. The relationship to the small bowel vasculature is by far the most important point to determine both resectability and progressibility. These can be complicated, and they can cause either bleeding, where the tumor erodes into the vasculature, or ischemia, where the tumor pinches off the vasculature of the small bowel, or fistulization. You know, as these tumors grow, sometimes they outgrow their blood supply. So they're growing, but they're growing so fast that their inner core is necrotic. And when that happens, and when they involve the bowel, sometimes the bowel will fistulize into them. The other complication was surgical resection, and this was one of the reasons that we've moved away from surgical resection, is you put patients at very high risk of getting short-gut, and it's very clear that intestinal transplantation is not the right thing to do in these cases. The natural history of desmoid tumors is quite variable, and this is the study I mentioned a little while ago. So the group in Milan, which does the lion's share of sarcoma surgery for Italy and has really been a driving force for all sarcomas of developing international and intercontinental partnerships, published back in 2009, published their experience with 142 patients with desmoid tumors who were treated at their institution. 83 of them were were treated with initially with close observation. Over 5 years, 50% of them progressed, which means 50% of them didn't. And then patients who were initially treated with intensive medical therapy, there were 59 of them, and over 5 years, 60% of them, 40% of them recurred. The p-value on this is 0.3. And one of the things that's interesting to me is this is 2009. In some ways, it's not that long ago. And the first sentence of their abstract is that surgery is still the standard treatment for desmoid fibromatosis. If you wrote an abstract today with that as your first sentence, it would not be accepted. And then just a couple of other papers. This another retrospective case series, 426 patients with sporadic desmoids who presented to 26 French centers. 75% of them were disease-free following initial surgery, which was often surgery. 50% of them recurred. And then only 20% of patients who were managed with close observation progressed. And this, again, gets to progressibility, and they were observing patients who they felt comfortable could grow a little bit, and it wouldn't affect things. But it was these clinical decisions and then the papers that were being published from it that led us to realize we didn't need to observe these patients. A lot of these tend to be associated with high estrogen states and trauma. And obviously pregnancy is both a high estrogen state and a traumatic state. And again, the Italian group, the group out of Milan, published a retrospective series in 2014 looking at 92 women who developed desmoid prior to, during, or in the 6 months period following pregnancy. They had very high rates of spontaneous regression in patients who were treated with watchful waiting, and I apologize, it should have said following delivery. And there were no obstetric complications in women who had a desmoid that was observed during their pregnancy. So overall, surgical resection is rarely first-line therapy for desmoid tumors. And initially when I wrote this, I wrote that I observe all abdominal wall desmoids. And then I realized I should put almost in, because you never want to say always or never in a talk. But I observe really almost all of them to begin with. And then most pregnant women with a desmoid tumor can be observed safely. And to be very clear, having a desmoid tumor is not in and of itself an indication for an abortion. There are, for treatment guidelines, there are multiple guidelines that exist. This is a flow chart from the European guidelines that were published a couple years ago, and I chose this over the NCCN guidelines because it's just a so much nicer one-page flow chart. But you can tell it starts with diagnosis, to hit that home again. Active surveillance is the initial frontline approach. And then if there's stabilization or regression, which is depending on the series, the event in somewhere between 50 and 75% of patients, obviously you just keep them on active surveillance. If they progress, depending on where they are, how progressible they are, you can keep watching them. If it's an abdominal wall desmoid, often the first line treatment is surgery. If it's not too morbid, if it's intra-abdominal, retroperitoneal, pelvic, or anywhere else, the first line treatment is systemic therapy. And with systemic therapy, multiple regimens have been tried over time. The goal really historically has been symptom control or stability as opposed to, tumor regression. And then just to talk about one medication, this was a gamma secretase inhibitor. The results of a clinical trial that were published in ESMO in August of last year. The company has approached the FDA for approval. The last anyone heard, it's going to be, quote, in the fall. But what this seems to be a better treatment than anything we've had before. Their study, which has been published in abstract form, but not a manuscript. And so you always have to worry about that a little bit. Showed improved overall response rates and also improvements in multiple patient-reported outcomes when compared to placebo. And so just like extremity or truncal tumors, specifically for desmoid tumors, if you're wondering when to refer them, you should refer them early. I will say if I'm meeting someone who's been observed with close observation by another physician, they come to me, and I've had a couple patients recently who say, well, I've been observed for a year or two. And I'm like, I tell them that we restart the clock when you come and see me, so that because I haven't had a chance to examine the patient, I haven't had a chance to really understand what their symptoms are doing based on my interviews. And so I and most other sarcoma surgeons restart the clock when someone comes and sees us. So now to talk about retroperitoneal sarcomas. And this is really what we're talking about. This was a recent sarcoma I took out of a patient. And for those of you who aren't used to looking at CAT scans, this is a CT scan of the abdomen and pelvis, and all of this black stuff here, this is her abdominal cavity, and this should be filled with intestines here and here, but this mass is just pushing everything out of the way, and the intestines are all squished down here. And this is another one, and I'll come back to these two different CAT scans in a second, but you can tell here this tumor is all very simple. It's fatty, it's nice, and it's not complex. And here, all of this is tumor. This is a much more aggressive tumor, and this actually is technically unresectable because of how it's involving some structures. And this, I'll come back to these slides in a second. So when it comes to workup, we always start with a history, and their symptoms are vague at best. They've had a little bit of reflux that's maybe gotten a little worse. They have a little bit of a change in bowel habits that's maybe gotten a little worse. Maybe they have some vague discomfort. And then it's either those symptoms that causes them to finally get a CAT scan, or often it's actually incidentally identified on cross-sectional imaging for some other reason. The cross-sectional imaging here is essential for operative planning. Really what I'm looking at is the relationship of the mass to both the resectable and the unresectable structures. So the aorta and the SMA are certainly unresectable. There are some places that are pretty aggressive about resecting the IVC and doing an interposition graft, or sometimes even just resecting it if it's been occluded for a long time by a tumor. Because these grow up in the retroperitoneum, nephrectomy is often required for a complete gross resection. And we either get dedicated imaging of the kidneys, or at least look at how the contralateral kidney looks and is how it's picking up contrast. And it's so important, and depending on the interval between when I see someone and I can get them to the operating room, I often reorder a CAT scan in the week or two preoperatively, so I really know what I'm looking at. And then, resectability, the notion of whether the tumor is pushing or invading matters a lot. So here, to come back to these original scans I showed you, this mass is just pushing everything out of the way. And so this mass actually shelled out pretty easily. This mass, however, is invading. So this is the aorta, and on this view here, this is the portal vein, and it was the portal vein, the celiac artery, and the SMA were all entirely encased. And so this patient is unresectable just because the organs that we're going to have to take out in order to resect her are, it's too much. It wasn't, the chance of morbidity or mortality as a result of this operation was too high, would have been too high. When it comes to biopsy, in the extremity, I said we're really worried about biopsy seeding. And there are two schools of thought for the retroperitoneum. One thought is these need surgical resection, and surgical resection is often first and historically was first. And a biopsy is not going to change that. The school of thought in favor of a biopsy is that histology-specific treatment requires knowing the histology. it turns out that for the retroperitoneum, the risk of percutaneous tract seeding is exceptionally low. So there have been 3 recent studies that have looked at the risk of biopsy tract seeding in resected retroperitoneal sarcomas. One of them showed a risk of 0.5%. One of them showed no patients had a recurrence. And then the highest risk we can find is 2%. That risk of 2% is markedly lower than the risk of local recurrence following surgery. And so as a result of that, I biopsy basically everybody or almost everybody with retroperitoneal masses prior to surgery. And then if it's a suspicious mass that looks like it's coming directly from the adrenal gland, I will get a functional workup to start, but that's pretty rare. The differential for these, if it's a sarcoma, there's about an 80% chance it's going to be either a liposarcoma, a leiomyosarcoma, or an undifferentiated pleomorphic sarcoma. There are benign masses that can often be observed, schwannoma, cystic lymphangioma, and then either an adrenal or a renal myolipoma. Those can all be observed, as can Castleman's disease. And then the other non-sarcomatous items on the differential, and this is obviously a short differential, but lymphoma, a metastatic cancer of some other origin, a hematoma and abscess from some other cause, or benign retroperitoneal fibrosis. There is TARPSWIG, which is the Transatlantic Australasian Retroperitoneal Sarcoma Working Group, is a international working group started by surgeons at OSU, Milan, Brigham and Women's Hospital, and several other high volume centers. They're now members in Europe, in North and South America, in Australia and East Asia. We're a member, and they put out a consensus statement for the management of a primary retroperitoneal sarcoma. A couple things to highlight here, and this link goes to that statement for anyone who wants to read the whole thing. But multidisciplinary expert management is key to the management of these tumors. Patients should be seen and treated at a sarcoma center that not only has expertise in sarcomas generally, but also does a minimum of 10 to 20 retroperitoneal sarcoma resections yearly. A fair number of these patients need preoperative nutrition supplementation. Excuse me. And any of my patients who I'm worried about their nutritional status, I have evaluated by our nutrition team, our dietitians, when they come and see me. It's also very much worth either considering getting dedicated imaging of the contralateral kidney if you're going to have to do a nephrectomy, or at the absolute very least, taking a look at how the contralateral kidney picks up contrast and making sure it looks reasonably healthy. There's a lot of ongoing debate on the use of neoadjuvant radiation therapy or systemic therapy. And then within our community, there is a little bit of a debate on extended compartment resection, and I'll talk about that too. 2 special situations to talk about. If you find yourself in the OR, someone's been taken to the OR for an adnexal mass, and then on exploration, they have normal tubes and ovaries, but there is a large retroperitoneal mass. There's this great instinct that you're there, and you're there for the wrong reason. You want to do something to the patient. And you please do not get a biopsy. If this is the case, unless you have good pre-op imaging and you have access to a sarcoma surgeon who can come and evaluate the patient in the operating room, and that almost never happens, you should absolutely just close, refer the patient, and then at a separate time get a percutaneous biopsy. The same is true if you've taken a patient to the OR to repair a hernia, especially a groin hernia, and on exploration, they don't have a hernia, but they do have a retroperitoneal mass that's growing through the inguinal canal. Again, same thing, do not get an intraoperative biopsy, just close and refer them, and we'll get a percutaneous biopsy. Getting an operative transabdominal biopsy absolutely has a has a very high risk of causing seeding. And that since their best chance at cure is their first operation would be the biopsy. There are some emergencies for retroperitoneal sarcomas, although that said, true intestinal obstruction is rare, true infection of these masses is rare, true uncontrollable bleeding or bleeding requiring multiple transfusions is rare. Nutritional deficiencies, which I put here again just to talk about again, these are actually quite common. But if you're a general surgeon or an ER doc or whatever, who sees a patient with a retroperitoneal mass with obstruction, infection, or bleeding, just treat that as you would treat it. Ignore the sarcoma. Just take care of the problem in front of you. And then we can take care of the sarcoma piece later. Now to talk about radiation, there has been for a while, surgical resection is known to be necessary for the treatment of retroperitoneal sarcoma, but it's also known to be insufficient. Local recurrence rates, depending on the institution and the series, are as high as 50% over 5 years. And for most of these, the cause of death is actually local recurrence. And so in several institutions have for a while been giving neoadjuvant radiation. This was tested in a large international randomized control trial that published their results in 2020 that compared surgery first versus neoadjuvant radiation. And the neoadjuvant radiation was 50.4 Gray given in 28 fractions. It was done at 31 institutions in 13 European and North American countries. 266 patients split evenly into 2 arms with a median follow-up of 43 months. And the primary endpoint was abdominal recurrence-free survival. The patients were well matched for age, histology, size, and grade. The rates of complete gross resection were equal between groups. However, the rates of transfusion were much higher in the neoadjuvant radiation group. And then interestingly, patients with liposarcoma who were randomized to the neoadjuvant radiation group were much more likely to need concomitant organ resection than those in the surgery first group. This was actually less common in the leiomyosarcoma group. This is their overall results. This is the risk of recurrence over 6 years. And you can see the surgery alone group is the red line, the radiation group is the blue line, and these lines are exactly the same. So this was a negative trial showing us that neoadjuvant radiation, when studied in a randomized prospective trial, does not result in an improvement in intra-abdominal recurrence. Or maybe. This was an unplanned analysis, and this actually going back to why pretreatment biopsy is so important and going back to histology evolving. The Strauss trial was designed when we didn't understand as much about histology specific behavior as we do now. And so there were no histology specific analyses planned. As we learned more about it, there was an unplanned analysis that looked at recurrence rates in patients with well-differentiated liposarcoma. And they found that the risk of recurrence was much lower in patients randomized to the neoadjuvant radiation group than it was in patients with well-differentiated liposarcoma who got surgery first. Some other circumstantial evidence that radiation might be better. This is a study that was published in Cancer last year. They performed a retrospective analysis of the Strauss trial radiation plans. And they found that even after pre-screening of the radiation plans, about 30% of them were non-compliant. They then compared recurrence in the patients who got compliant radiation to recurrence in patients who got non-compliant radiation. And they found that patients who got non-compliant radiation had lower rates of recurrence than patients who got compliant radiation. Another study that was just published in the Annals of Surgical Oncology last year was a retrospective analysis of patients treated at the University of Toronto. And they ran these patients through 4 different nomograms that try and predict recurrence following retroperitoneal sarcoma resection. So they ran them through the nomogram at MD Anderson, at Memorial Sloan Kettering, a nomogram from the Milan group in Italy, and then a tri-institutional nomogram that was created with patients from Milan, Sloan Kettering, and UCLA. They had 253 patients treated over 20 years. And what's important to notice here, or to know here, is that at the University of Toronto, they're very high frequency users of radiation. So they believe in radiation. And what they found, and they don't have a great picture for me to put up here, but what they found was that in patients with well-differentiated liposarcoma treated at Toronto with neoadjuvant radiation, the Sloan Kettering nomogram dramatically overestimated the risk of local recurrence. This was not true in patients who did not receive neoadjuvant radiation. So if you showed up at the University of Toronto with well-differentiated liposarcoma and you got surgery first, the MSK nomogram predicted your risk of recurrence pretty well. If you got radiation first, the MSK nomogram said your risk of recurrence was much higher than the Toronto experience was. So what does this tell me? This tells me a couple things. It tells me that histology matters. It tells me that the experience of the surgeon and the radiation oncologist matters. What I don't know what to make of all of this is all of the radiation oncologists in the Strauss trial practiced at high volume sarcoma centers. And not only did they practice at high volume sarcoma centers, but they practiced at high volume sarcoma centers that were interested in clinical trials and interested in a radiation clinical trial. What's hard for me here is I don't know how to assess radiation oncology treatment plans. So I can't look at my colleagues' treatment plans and say that their target volume is wrong or the anatomy that they're highlighting is wrong. Now, at the same time, the radiation and medical oncologists don't know how to assess surgery, and they can't say that I know how to do a good operation or I don't know how to do a good operation. So as it stands today, I'm not ready to use neoadjuvant radiation for primary resectable retroperitoneal sarcoma outside of a clinical trial. However, I will enroll all of my patients on a clinical trial if we have one. We don't have one yet. The sarcoma community is starting to talk about what that trial would look like. But as you all know, there's a long process between thinking you want a trial and then defining it and actually having it happen. But when it opens, if it's a trial we like, we'll absolutely open it here at KU. The next question is if giving radiation prior to surgery doesn't help and doesn't decrease the risk of recurrence, can giving systemic therapy help and decrease the risk of recurrence? And the answer to that as it stands today is that we really don't know. I put sarcoma here in quotes because as I've hinted at, all of the sarcoma histologies are very different. One thing they have in common is most of them are pretty insensitive to systemic therapy. And this is because, as ironically as it seems to hear from a surgeon who talks about taking out tumors that weigh 20, 30, and 40 pounds, these sarcomas tend to be slow growing and they tend to not respond to systemic therapy very well. So today, as best as we can tell, patients who should get systemic therapy are patients with large aggressive tumors who have some combination of systemic symptoms and poor nutritional status. And what we find when you give those tumors or when you give those patients systemic therapy, it's not like the tumor goes away. So it's not someone who's got colorectal cancer that's metastasized to the liver. You can give them chemo and the liver met's going to go away. But what does happen is the tumor seems to sterilize, and the patient's systemic symptoms, their fevers, their chills, their weakness gets better, their poor appetite gets better or and they start eating more, they start gaining some weight, they start getting some activity. It doesn't make the tumor any smaller for me, but it probably does make them allow us to get them in better shape for them to end up tolerating surgery. And so that's the approach today. The approach tomorrow is going to be Strauss 2. This is another large multi-center trial, again, coming out of Europe, that's randomizing patients with high-grade liposarcoma or with high-grade leiomyosarcoma, either to a surgery first approach or to a neoadjuvant chemotherapy approach. This is open in Europe, and it's open in Asia, and it's opening in the United States soon. I put soon in quotes because it's been soon for about a year. But I heard from our clinical trials folks that it's hopefully going to be within the month that it's going to be open within the cooperative group program in the US, and then we'll just have to go through the steps of physically opening it here. But we're really excited to get this, and we have several patients a year that'll be eligible. So the last debate to talk about in the sarcoma world, and this is a very surgically focused thing, but this is this question of extended compartment resection. And the question here is, does taking organs that are immediately adjacent to, but not directly involved with the sarcoma, change the rates of local recurrence? This is not something we'd ever be able to study prospectively, and it's very hard to study retrospectively because there's so much unmeasured bias and there's so much confounding by indication and institutional practice patterns with where you're treated. There are also some very, very big feelings in the sarcoma world on this issue. It's absolutely standard in Europe. It's less standard in the United States. And the one thing we do know to be true is if a surgeon peels, let's say, the colon off a tumor, but then in doing that, the colon's devascularized, so it's resected and sent to pathology. It's rare that the pathologist finds viable tumor on that specimen, which is why some people argue that you shouldn't do it. To me, I do it on a case-by-case basis. If an organ, and really, again, what we're talking about here is often the bowel. If the bowel will come off without a lot of work, then I'll take it off and leave bowel behind in the abdomen. If it's quite stuck, and certainly if it's involved, that's no question. But if it's arbitrarily too hard to separate the bowel from the tumor, then absolutely I will perform a bowel resection and anastomosis at the same time. And just like extremity sarcoma, and just like desmoid tumors, if you have someone with a retroperitoneal sarcoma, please refer them either to KU or another high volume sarcoma center sooner rather than later. And again, caveats, even more so than many other tumors, the management of sarcoma, to me, is based on some combination of science, practice, and belief. I've tried here to split the difference between what the science is, what the practice patterns is, and what my strongly held feelings are. Very clearly, and this is science, in fact, that all sarcomas should be managed from workup on at a specialty sarcoma center. So thank you very much. If you have any questions, this is my email. It's lselby@kumc.edu. And if you have any patients with sarcoma or with anything else and you want to get in touch with our awesome nurse navigators, this is their phone number. So with that, I'm obviously happy to take any questions now, or if you're watching this later, happy to take any questions later.
Dr. Selby, thank you. That was a fantastic presentation of an amazingly broad topic, which you distilled down just beautifully. I think one of the goals that we had kind of talked about for our talk tonight was, how do those surgeons out in the community, how do you weed through these things? And so out of curiosity, so the patient, like you mentioned, you're in there, maybe a misdiagnosis, and all of a sudden it's a retroperitoneal finding that you have. Curious what the difference between a core needle or percutaneous biopsy and lack of seeding versus in the operating room and a direct incisional biopsy. What's the pathogenesis, do you think?
So I think what it is, when you're getting a core needle biopsy, it's getting done by IR and they're going transabdominally. And so the place where you would theoretically be seeding it, there's not a lot of opportunity for the tumor to spread there. There's not a lot of space for the tumor to spread through a retroperitoneal needle track.
You're saying they would biopsy retroperitoneal, not transabdominal.
Yes. Yeah. So their approach is almost always retroperitoneal, and they're doing it because they don't want to hit, they don't want to hit the bowel. And the easiest way to the retroperitoneum, if you can flip someone over, is through the retroperitoneum, obviously. We know the biggest risk of local recurrence, or one of the biggest risks of local recurrence following complete gross resection of a sarcoma, is an incomplete resection, and actually therefore a non-complete gross resection. And so an incisional biopsy is, all you're doing is you're cutting open the tumor and you're getting it. And so the contrast between the retroperitoneum and an extremity is, if you have someone with a thigh mass and you're doing an incisional biopsy, the only place where you are seeding tumor, and this is why those incisional biopsies should be done by the eventual treating surgeon, the only place where you are seeding tumor is in the planned excision, where the patient is going to have this whole thing, including their initial incision, taken out. I can't take out the peritoneal cavity. So when that incision is made, and the tumor capsule is violated, we know tumor spills. And even though these are slow growing cancers are still fast growing. And so what it is that it's seeding tumor over the whole peritoneal cavity.
Great, thank you. I know Mary Beth put in the chat line, but if anyone has questions, feel free to either put them in the chat box, or if you'd like to unmute yourself and ask questions as well. Satellite Wi-Fi, yay.
Yeah.
If there's any questions in general, Commission on Cancer new standards, feel free to put those in as well. If it's a hard question, I'll just pretend like my satellite internet froze. And just other things for the group for comments, questions, or discussion. If there's any topics that come up in your tumor conferences, any discussion topics that you would like in the future, we would love to have ideas on what you'd like to hear about. I know in our next talk in April or May, I'd have to look at the date again, but Dr. Al Caspools is
I think she froze.
Yeah.
Yeah, April 10th is the next date.
April 10th, is that what you have, Hope?
Yes, I have April 10th and HIPEC.
Perfect. And my internet didn't freeze at all during your talk, Luke. Elon Musk was riveted using satellite technology to watch your presentation. And that is the truth. It didn't freeze once during your talk.
Dr. Selby, enjoyed the talk. Can you hear me?
Yeah.
Hey, I was wondering, are similar to how Gleevec kind of revolutionized GIST, and I realize they're a little bit different horse that we're dealing with in retroperitoneum, but have there been research? Has there been research regarding immunotherapy for the retroperitoneum?
So immunotherapy is being looked at in a host of different sarcomas. And we're nothing, it hasn't really hit the retroperitoneum out of the ballpark yet. We're hoping that some of the extremity sarcoma subtypes are fast growing enough and therefore mutationally complex enough that immunotherapy will work well for them. In the retroperitoneum, I didn't get into this because I didn't want to make everyone fall asleep. But for liposarcoma, a hallmark, and in fact, it's required for the diagnosis, is a finding of MDM2 amplification. MDM2 amplification results in constitutive activation of CDK4 and CDK6. And we have a host of CDK4 and 6 inhibitors that initially grew up in the breast population that are FDA approved for unresectable liposarcoma. We haven't really figured out how to get them to work. And so people, when the initial work was published in like 2016, 2017, everyone thought, oh my God, this is going to be it. This is what we've been looking for. And at least in patients who have recurred with visible disease, they don't seem to slow down the growth that much. There are some institutions in OSU where I did fellowship as one of them that, based on risk of recurrence, will off-label give palbociclib specifically to anyone who's had a complete gross resection of a retroperitoneal sarcoma. But that's not ready for prime time yet.
Thanks.
We're looking for it though, because it's, surgery is necessary, but it's not sufficient. And, I tell all of my patients that sarcoma is a recurrent disease, and that, they come and see me and I get all their scans. I mean, to the point I tell all my patients that from the moment I've operated on them, that no one operates on their abdomen if they're not me or they're not someone I work with, because what you don't, these patients, it's because it's a recurrent disease and because we don't have anything else, when someone's recurred, we end up at some point reoperating on them. And then we often end up reoperating on them again. And as you know, there are only so many XLAPs you get. Another consequence of this is that these patients are nutritionally depleted, getting major XLAPs, so their hernia rate is very, very high. And so on surveillance imaging, when they're found to have an incisional hernia, and not if, but when, I tell them we're going to watch it and we're going to get a couple years out from a recurrence before we go back in and do a real hernia repair. Because again, you only get so many times in the belly that we don't want to fix our hernia at 6 months and then 3 months later have there be a recurrence, or I don't want to have them get their hernia fixed by a local surgeon who's not using that opportunity to go and look in the belly for recurrence.
Those are great points. And I think for all general surgeons in the audience, certainly, important points. Because a simple hernia isn't always a simple hernia. That's great.
Yeah.
Do we have any other questions at all from the group? All right. Well, again, Dr. Selby, just absolutely fantastic presentation. That was wonderful, truly was. And I'm thrilled that we have that recorded because I think we're going to have a lot of interest after the fact
Yeah.
it's wonderful at the time, but we're going to have a lot of interest after the fact too. Mary Beth or Hope, do